talk about the new guideline on the bowel cancer screening program. Please, Dr. Vega.
Thank you very much for having me here today, and I really appreciate that Professor Sanders thought of me. Here is where my journey on the bowel cancer screening actually began 11 years ago, when I came to a very amazing course to be prepared for the accreditation. So I feel very honored to be back in Sheffield explaining things about bowel cancer screening. So the title of my talk emphasizes what do I tell my patients. And before I start to understand together with you the new guidelines and how to implement, I just would like to mention very briefly how important is the communication skills with the patients. In order to be able to convey a message that reassures the patients, we have to make sure we understand the guidelines and we present to them the evidence of surveillance, the benefits and risks of undertaking surveillance colonoscopies with them. Also, it's a great opportunity to talk to them about evidence-based other interventions in terms of lifestyle and so forth that perhaps would play a role on changing the natural path of this disease. Always using understandable language is very important, and also having to account the views and the experience the patients have had towards colonoscopy in order to make a plan together. And when we change treatment plan, especially if we are going to send them to another pathway away from us, we have to reassure the patients that they can always come back to us and for further queries or for symptoms, so that basically they don't convey a message that they have been abandoned because of new guidelines. And I think that's very important. So just a very brief summary why these guidelines are needed. Well, because colorectal cancer, it's a very prevalent disease. So we have nearly 40,000 cases diagnosed every year and 16,000 deaths a year. So it's the fourth most common cause of cancer and the second common cause of cancer death. So that's why we are all in this venture to try to make these figures a bit better. We perform about 500,000 colonoscopies in the UK a year. And obviously the polypectomy has been proven to reduce colorectal cancer and mortality. And believe it or not, through all the colonoscopy patients that come to our units, nearly 15% of colonoscopies are surveillance colonoscopies in the UK. So it's a huge burden for an overstretched service already. So when we see polyps, it doesn't matter of the size or the type. You can have a diminute polyp, you can have a serrated lesion, you can have a traditional serrated adenoma, you name it. Always you think, shall I start surveillance? When do I start the surveillance? When to stop? And now with the new guidelines, something else. We may need to change plan of what we told the patient first. If we think about it, and that's a bit the adenoma-carcinoma sequence that probably we are all quite familiarized with, nearly after our second sort of a half century of life, between 25 and 50% of us would have developed an adenoma. But only 5% of the population develops cancer, so not all the adenomas translate into bowel cancer, and it can take between 10 and 15 years. So perhaps we are surveying patients too often or too much for what the resultant general population is. Just a very quick refresher about our previous guidelines that we were all very familiarized, that they were quite easy to understand and easy to implement, so most of us were adhering. There were guidelines that they were written in 2000 and published in 2002. The UK had not embraced into a systematic surveillance program at that time. And things have moved on in terms of the quality that we provide to our patients since. So these guidelines were very simple. There was a top line that said baseline colonoscopy with no other definitions. And then you were categorizing patients with low risk, intermediate risk, high risk, depending on the number and the size of polyps. And you could put the patient in a loop and keep interchanging between different types of risks, depends on what you were finding in each colonoscopy, which meant that there were patients that perhaps had polyps that wouldn't translate to any significant high risk later on, that were kept in a loop of constant surveillance. So that's why a need for a new guidelines was in there. So basically in the new guidelines, what happened in a nutshell? So here you can see these guidelines were only for adenomas, but we have all come across the new boy in town, so the serrated lesions, and we know there is a clear pathway also from serrated lesions to colorectal cancer. And then basically the intermediate risk has been eliminated. And then you have as a summary these new guidelines. So the first time I saw the algorithm, it feels a little bit overwhelming with a lot of definitions and exceptions and arrows here and there, but when you spend a bit of time, then starts making a bit of sense. And I'm going to try to go bit by bit on this algorithm in order for all of us to start understanding how we implement it. The first thing that is different from the previous guidelines is the baseline colonoscopy. And this is key for the guidelines to be successfully implemented and for having good outcomes for patients. So in our baseline colonoscopies, we have to ensure that we deliver high quality colonoscopy. Otherwise, the new guidelines are not going to work. And what do we mean by that? So we mean that we have to intubate the cecum and actually truly intubate the cecum and explore the cecum and document the cecum, like the picture you have in the center, that you have a nice appendix in there. The bowel preparation has to be high quality, and we need to spend time washing and removing any puddles of fluid that may masquerade any flat polyps that we may miss. When we do therapy, even if it's therapy in very small polyps, we have to do it in detail and also with high quality, ensuring that when we snare the polyps, we include the whole polypoid tissue in the snare, we go back and inspect the site and ensure that we don't leave anything behind, otherwise we will have recurrence. And if we have polyps that are larger than 19 millimeters or 2 centimeters, we have to ensure that we survey these patients sooner. Believe it or not, in polyps more than 1 centimeter, the incomplete resection is about 10%, even in expert hands, especially if we are in a rush. So this baseline colonoscopy exercise is key for the rest of the guidelines to be implemented safely. Secondly, let's go to the bit of the guideline that says that we may need to survey the large non-pedunculated colorectal cancers. The guidelines state that we should do a site check between 2 and 6 months after the resection, and then we should bring the patient one more time after 12 months from the previous check, so in 18 months since the initial intervention. Why is that? You can see here in the left-hand side a recurrence of a polyp that was removed piecemeal and how has come back. So lesions larger than 40 millimeters have a very high recurrence rate. And when a polyp is going to recur, 76% of these patients, we will see the recurrence in 3 months. But if we push it a little bit farther and we do our surveillance colonoscopy in 6 months, we will pick up nearly 96% of this recurrence. The recurrence rate generally in piecemeal EMR is about 22%. And if you do an en bloc resection, like the picture you have on your right-hand side, the recurrence rate is extremely low. So always bring patients back in order to avoid difficulties on controlling these issues. Now let's go to the exceptions and what do we do with patients when they don't have any high-risk findings. So the guidelines say that if you don't have any high-risk findings, and we will go to the definition of what it means in a couple of slides down, you shouldn't engage the patients on surveillance colonoscopy and encourage them to participate into the bowel cancer screening program, back again just sending the stool samples for fit testing. However, there are exceptions. These two pictures that you have here, they look very similar polyps, but they are from two different patients I came across a few weeks ago. The picture on the top is a 29-year-old patient, and the picture at the bottom is a 77-year-old patient. So obviously the advice you have to give these patients is very different. So very small diminutive polyp in a 27-year-old patient perhaps doesn't require surveillance according to these guidelines, but on a 29-year-old, then it's different. You may need to ask them to perhaps have another colonoscopy in 5 or 10 years' time. Let's talk about what is the high-risk findings. So if you have about greater than 2 premalignant polyps, and one of them is an advanced colorectal polyp, patients should have a one-off colonoscopy in 3 years. And if you have 3 malignant polyps, the same. What is the definition of a premalignant polyp? We should be familiarized on what a serrated polyp is, like the picture you have on the top of the slide, or what an advanced colorectal polyp is as well. So any adenomas that would be greater than 10 millimeters or serrated lesions with dysplasia or features of high-grade dysplasia. So get familiarized with this nomenclature and it will be better to implement the guidelines. Just a very quick snapshot about the experience, our local experience at UCH when the new guidelines came across. So UCH delivers the bowel cancer screening for the north central London area, and that was rolled out in 2007. We deliver bowel cancer screening in 1.5 million population, and that's across 5 CCGs. So we have done probably in total about 9,000 colonoscopies as part of the screening, and over 350 cancers have been diagnosed. So when the new guidelines came across, we had 677 patients that were due for surveillance. And after we did the exercise of implementing the guidelines, we were able to send to fit testing 419, which obviously created a bit more capacity for our unit. So in conclusion, to truly assess patients about the implementation of new guidelines, the high-quality colonoscopy is key. High-quality endoscopy resection is also key. You need to promote the implementation of the guidelines locally and everybody having an understanding, and always involve the patients in the care plan and the pathways for reconsideration, so they don't feel you are abandoning them because you are changing plans and not doing surveillance anymore. Thank you very much.
Thank you, Rosa, for excellent talk. Unfortunately, we have not had any questions from the audience, but just wondered if you could give us your view about resect and discard policy of sub-centimeter polyps.
Resect and discard.
Discard.
And my view, obviously, if you have the luxury in your, or you are lucky in your local setting to have high definition scopes that you can perform decent electronic chromoendoscopy with NBI or iScan, depending on the platform that you are using, or with the Fuji BLI. You can predict quite quite closely the nature of the polyps that you have resected in terms, and obviously now with artificial intelligence you have an extra layer that probably will help you to distinguish. However, there hasn't been any studies that when you implement that to the broad community, the sensitivity of the polyps that you maybe label as an adenoma is high enough to just discard. So I think either more training models or a bit of, or technology needs to be put into place in order to ensure that the sensitivity and specificity of doing that and characterizing your polyps is taken across the board.
In the interest of time, we're going to finish the talk. Thank you. Thanks very much.